To have the opportunity to present some of the work that we've been doing at Royal Papworth Hospital for the last 5 years with regards to opioid free anaesthesia for thoracic surgery. So my name is Chinmay Patvardhan. I am a cardiothoracic anaesthetist. So I have no conflicts of interest to declare. And the aim of today's talk is to discuss the concept of opioid-free anaesthesia and how it sort of dovetails into thoracic surgery perfectly. I'm not going to speak about opioid-free anaesthesia in non-thoracic cases because I simply don't have any experience of it. I will discuss the opioid-free technique that we use at Royal Papworth Hospital, some of the outcomes, some of the publications that we've done, and I'm happy to take any questions after that. So to start with a historical timeline of opioids, opioids have been around for best part of 4,000 years, but the synthetic use of opioid really started around 1800. Before that, it was the natural form of opium that was predominantly used in medical field. 1803, synthetic morphine was isolated in Germany. 26, hydromorphone came into the US practice. The real change in anesthesia actually happened in around 60s when synthetic fentanyl was isolated and manufactured in Belgium. Sufentanil came around at the same time. Ketamine came out in 1970s, alfentanil in 76. And the other sea change in anesthesia with regards to remifentanil introduction and oxycodone, which caused all sorts of problems, happened in about 1996. Dexmedetomidine, which is not really an opioid, came about in 1999, initially in ICU, and subsequently over the last 20 years, people have been using it increasingly in anesthesia. Similarly, if you look at how anesthesia sort of evolved in response to all the drugs becoming available, the concept of balanced anesthesia, where instead of using a single induction agent, which caused a lot of problems with hemodynamic instability, the concept of using balanced anesthesia was actually sort of came out around 1926 at the Mayo Clinic in Minnesota by Dr. Lundy, who was the pioneer anesthetist and also did a lot of work in establishing transfusion program and transfusion safety in Minnesota. So the other important landmark in anesthesia was the publication of the Liverpool anesthetic technique in about 1946 by Cecil Gray and Halton. And Dr. Gray, I trained in Manchester and Liverpool, so Dr. Gray's pioneer work in anesthesia is actually the concept of the anesthetic triad, and I'll come to that in a minute. But interestingly, not many people know that Dr. Gray actually revisited his triad in a paper published in 1960, which is hardly ever quoted in the medical literature. What happened between 1946 with pethidine and around 1960 was increasing use of opioids, which were used in the name of hemodynamic stability, causing patients to have opioid-related problems in patients. And Dr. Gray actually revisited this in his paper. And he made a distinction between sympatholysis and analgesia, and I'll come to that in about. The first, I don't really know when opioid-free anesthesia actually started, but the first publication that I could see where opioid-free anesthesia was discussed was by Dr. Mulier, Jean Mulier, from Bruges in about 2013. And in 2018, since about 2015, 2018, anesthetists have increasingly started using the concept of multimodal anesthesia. And for people who are interested in this history, I have put a little note on the slide, which has got the publication, which will give you the history of the Liverpool anesthetic technique and what I mentioned about Dr. Gray. So the triad of anesthesia is really very simple and everyone knows about it. At the top, you've got hypnosis along with sympatholysis, and that's achieved by using a standard induction agent, inhalation agent, and TIVA. On one side, you've got muscle relaxants, which started with curare, and now we've got rocuronium. And then at the bottom, we've got analgesia. There's the WHO pain ladder. As anesthetists, we are all used to doing nerve block, neuraxial blockade, local anesthetic infusions. And for sympatholysis, we've got other adjuncts like alpha agonists. I shouldn't have included ketamine in that. Beta blockers is the other one that I should have included. So we all are familiar with problems with opioids, and particularly with my thoracic surgical patients. Last year I anesthetized about 400 thoracic cases, and every single one of them, about 90% of them are smokers. They're frail, they're elderly, they have got lots of secretions. And if you actually look at the word cloud, we all know what the problems are: nausea, drowsiness, CO2 retention, inability to cough. Especially in the elderly, you have problems with delirium, urinary retention, hypotension, pruritus, and some of them sadly end up in intensive care because of ineffective analgesia. And that's probably because of this vicious cycle that patients who undergo thoracic surgery get trapped in. We know thoracic surgery is one of the most painful surgeries you can undergo. So if you have ineffective pain relief and then you use opioids as a rescue, because at this point you really haven't got a choice if your local block is not working, they become increasingly drowsy. They don't take a deep breath. As a result, they develop atelectasis, CO2 retention, hypoxia. Sorry, my slides are playing up. CO2 retentions, hypoxia, and then respiratory failure. And at every step of this cycle, opioids have a negative effect on the patient. So we know the recent Society for Pain, the Faculty for Pain Medicine came out with the best practice guidelines for use of opioids in surgery in 2021, and they mentioned that intraoperative pain management techniques should include multimodal analgesia and opioid-sparing techniques. And these are really the drivers behind why we moved from using opioids as the standard for pain management for our thoracic surgical patients and moving towards opioid-free techniques for patients undergoing thoracic surgery. So the particular problem with opioids, and this is increasingly getting recognized in experimental literature, is that opioids themselves have negative effects on tumor progression. There have been studies in breast cancer and renal cell cancer and lung cancer where they have shown that higher use of opioids has a negative influence on the cancer outcomes, and there are larger scale studies coming out in the next couple of years. There have been a number of publications, but the data is still experimental and retrospective. So just to make it really simple, general anesthesia itself, an immune suppressive case, use of opioid causes reduction in the number of natural killer cells and reduces the tumor clearance ability of the natural killer cells in the body. Opioids have a direct cytotoxic effect on the natural killer cells, and opioid receptors have a number of tumors. The studies of the tumors have shown that the tumor itself has opioid receptors, mu receptors, and use of opioid promotes angiogenesis through the vascular endothelial growth factor, and that leads to a direct proliferation of the tumor and direct effect on the vascular endothelium that promotes angiogenesis within the tumor. Now, most of these studies are experimental, but I think in the next 5 years there is a large-scale Australian study about to come out, so watch the space. So with this in the background, with use of opioid-free techniques, it is possible to give effective analgesia and minimize the use of opioids. And I use the word minimize because I think the word opioid-free gives an impression that we are not giving any opioids to the patients at all. While that might be the case in an intraoperative period, in the post-operative period, we do give them opioids for pain management, and I'll come to the reasoning behind that later. It does not eliminate the use of opioids in recovery. So if the patient needs it, we certainly give opioids, but it does allow for a significant opioid sparing effect, and thereby we reduce the side effects for the patient. And all in all, it goes hand in hand with enhanced recovery of thoracic surgical patients, and I will discuss the results later. So what is opioid free? So coming back to the basic triad of anesthesia. So if you start with hypnosis, we use the same hypnotic agents as you do. Your propofol is the same as my propofol. We use inhalational agents for maintenance. So sevoflurane is the inhalational agents of choice in our hospital. We don't have desflurane. And some of my colleagues do use TIVA with or without remifentanil. Muscle relaxation is muscle relaxation. Now, when it comes to the aspect of sympatholysis, we do things slightly differently when it comes to the induction aspect of the patient, and we use alpha block clonidine, short-acting beta blockers, and we sometimes use ketamine along with propofol, depending on the case. We use the same combination of multimodal analgesia as you might use in your hospital, which includes non-steroidals, paracetamols. In a select group of patients, we use the gabapentinoids, and some of our more complex chest wall resections, reconstructions will have ketamine infusions along with alpha agonists. We do a lot of neuraxial blocks, and we use a lot of nerve blocks. So essentially, the only thing you're not using in an induction of patient is your routine fentanyl. I think thoracic surgery is brilliant for trying out opioid-free anesthesia if you haven't tried it, purely because the chest wall is very amenable to various nerve blocks and neuraxial blockades. So right from the back, you can do a spinal intrathecal opioids, but that defeats the purpose of doing opioid-free anesthesia. You can use a plain epidural, but the problem then comes is that you have a patient that is tethered to an epidural for 3 or 4 days. You can do a rectospinal block, you can do paravertebral blocks, you can do various chest wall plane blocks like serratus blocks, rectospinal blocks, PEX blocks, and thoracic transversus thoracic blocks, depending on what site of surgery the patient is undergoing. But I will talk about my experience about this in a minute. So how do we do opioid free? So the PAPWORTH recipe is as follows. So when the patient gets seen in the pre-op clinic, where occasionally a pain nurse comes in, and we do a lot of discussion, but increasingly because of the way the lists are going and the cancellations. And our experience in the last 4 years, we no longer use gabapentinoids as a pre-med. When the patient comes in, they get lined up and pre-oxygenated like normal. All of our patients, when they come in, first get 1 milligram per kilogram of lignocaine 1% and 1 microgram per kilogram of clonidine 1%. When I started opioid-free anesthesia in 2018, we started off with using dexmedetomidine, ketamine, along with lignocaine and clonidine, along with lignocaine, for achieving sympatholytic conditions. And what basically I observed in over, I think I've done about 900 cases of opioid-free, is that what I found with dexmedetomidine infusions and clonidine infusions is first of all, they're clunky. You need to draw up a syringe and start an infusion. But what I found out later on is there's no actually value added to it. My patients were waking up more drowsy, and they were drowsy for a longer time. Although they were not in pain, they were sleepy. So that defeats the whole purpose of enhanced recovery, I think, because what we like to do is have an awake patient that then goes to the ward, and the physiotherapist immediately start doing exercises with them to help their lungs to expand. So that's the reason behind why we don't use dexmedetomidine infusions. And what we found that through trial and error is by just giving them a single shot clonidine, 1 milligram per kilogram and 1 microgram per kilogram of clonidine, achieves the same sympatholysis that we need for laryngoscopy. We sometimes, depending on how the patient's hemodynamics are, used about 20 millimoles of magnesium. We induce them with propofol. Well, this is my personal choice to use propofol, atracurium, and then normal 0.8, 0.9 mac of sevoflurane, and we maintain with gas and air. We give them dexamethasone and ondansetron, and I give them paracetamol 1 gram early, along with some parecoxib. When the patient's positioned on the side, my technique of choice when it comes to nerve block is paravertebral block. I have used all the blocks that are described in thoracic anesthesia. So I've used epidural, paravertebrals, serratus, erector spinae, and I think in my clinical experience, all of them work, but in my personal opinion, none of these blocks are, if you're doing a combination of, let me just rephrase it, if you're doing a combination of a half dose fentanyl with a little bit of morphine, then I think an erector spinae block or a serratus block would be perfect. I think if you're doing a completely opioid-free thoracic video-assisted thoracoscopy procedure, in my experience, and increasingly my colleagues think the same as well, is that a good paravertebral block gives you a better sympathetic blockade than any of the peripheral blocks that you use. And erector spinae is probably okay. So I just stick to paravertebral blocks, and my standard mixture is 40 mils of 0.25% carotene with 1 in 200,000 adrenaline. Once the paravertebral block is done, we drop the lung and ask the surgeon to go ahead. The important thing is that at the time of skin incision, at every time you position the patient, you have to look at the heart rate and blood pressure, purely because the paravertebral block does drop your blood pressure, so you have to keep on top of that. Once in our institution, once the surgeon goes in, we don't ask them to block the phrenic nerve early. We facilitate the surgery. Once the lobe comes out and the lymph nodes come out, we give them 5 mils of 0.125% bupivacaine and ask the surgeon to infiltrate the phrenic nerve and the vagus at the top. And that takes care of the shoulder tip pain that patients sometimes complain afterwards. For belt and braces, if it's a prolonged surgery, we also ask them to do intercostal blocks from the inside. And then we give them paracetamol, non-steroidals, and a standard morphine PCA. But before that, I'll just talk about this intrapleural lignocaine. We started doing this technique in 2018, and in the early days, we still had a proportion of patients. Our patients were waking up comfortable and pain-free, but a proportion of patients were complaining of vague chest pain related to the drain that was sitting right on top of the chest wall in the apex. And we tried different things, and one of the things that worked was intrapleural lignocaine. So what I have started doing is, towards the end of the case, once the drain goes in, I give the surgeon 10 mils of 2% lignocaine with adrenaline. We squirt it directly into the chest wall. The local anesthetic sits in a puddle, and the lung is expanded, so it spreads around. And at the end, the surgeon connects up the topaz, which is a negative suction drain. It sucks out all the local anesthetic. So that gives us additional safety. Patients extubated in theatre, we take them to recovery. And in the recovery, we connect them up to morphine PCA, standard morphine PCA, and then we write them up a regular paracetamol plus minus non-steroidals. If they have a thoracotomy, we put an extrapleural catheter and connect that up to a local anesthetic infusion, which we carry on for 3 days. And we give them 6 weeks worth of gabapentin. If they have a simple video-assisted thoracoscopy procedure, the morphine PCA is continued for 24 hours, and the following morning the PCA is converted to codeine, and the patient goes home afterwards. I'll just show you a quick video, I hope this works, of the phrenic. So this is where the phrenic is, which looks like a shoestring, and the other one is the vagus. So what we're looking at is the apex of what we're looking at, the left lung here, So that's the apex. That's where your brachial plexus, your subclavian artery is, and your superior vena cava is coming down with the azygos, and then you've got the phrenic, and on the other side vagus, and you've got the trachea. So what we get the surgeon to do is use a needle on a butterfly, and we ask them to infiltrate at the apex into the fat pad. And since we've started doing this, we almost have no issues with patients complaining of shoulder tip pain afterwards. We use them in all the patients, including the lung volume reduction surgery patients who've got extremely low FEV1. We've used this in patients with myasthenia. I've never had any problems with diaphragmatic paralysis causing respiratory depression. So post-op, like I mentioned, we use paracetamol and non-steroidals, paravertebral catheter if it's the thoracostomy, 6 weeks of gabapentin, and the PC is taken down at 24 hours. At 24 hours, it's a medical assessment to see if they require codeine or if they require anything stronger. But a vast majority of these patients are just fine on 30 milligrams codeine 3 times a day. So what's our experience with opioid-free anesthesia and PAPWORTH? So we are the only center who exclusively do opioid-free thoracic surgery. I started in 2018, do majority thoracic anesthesia, and all 3 of them use the opioid. A slight variation being one of my colleagues uses an extrapleural as an erectospiny catheter. We do almost all the procedures with an opioid-free technique, which includes a mixture of pleural procedures, wedge resections, lobectomy, lung volume reductions, thoracotomies, airway reconstructions, you name it. We've also done about 19 opioid-free cardiac cases, which include a mixture of anything from a CABG all the way to an aortic arch using the same technique with a slight modification of blocks. In 2020, we published our experience and evidence that we gathered about opioid-free anesthesia for lung cancer resection surgery. It was a retrospective case control study. And essentially, we demonstrated that using an opioid-free technique for lung cancer resection is feasible, safe, and results in non-inferior pain relief and morphine consumption as compared to a standard anesthetic technique. So we had 83 patients in each group. All of them had a video-assisted lobectomy. Our median length of stay was 3 days with an interquartile range of anything between 2 days and 4 days. Median length in recovery was about 119 minutes. Bear in mind, the duration of time spent in recovery also included how much time we needed for the porters to come and pick up the patient. But the patients woke up significantly better with opioid-free. They were awake, pain-free, and suitable to be discharged to the ward, down from 169 minutes in 2015, where we were exclusively opioid-based. The pain scores were comparable. The mean post-op morphine consumption, and I forgot to write, at 24 hours was about 16 milligrams and plus minus standard deviation at 20. But the pain scores, the median pain scores at hour 1 was significantly better in the opioid-free group as compared to the standard group. There was no difference in analgesia at 24 hours with propensity matching. And there was no difference in time spent in recovery when we actually did the analysis. But we know from retrospective data that we've got from 2015, this opioid-free has allowed us to send our patients back to the ward quickly. Like I said, there was a reduced length of stay from standard for standard group was about 4 days, and for opioid-free was about 3 days, 2 to 6, 2 to 4. But unfortunately, the p-value wasn't significant. What are the problems that I've had with opioid-free anesthesia exclusively when it comes to thoracic surgery? I think giving morphine or fentanyl hides a lot of sins. So small things like keeping the patient's neck in a neutral position, or making sure that when the patient's on the side, there is a good padding under the hips or the ankles don't sit on top of each other, and there's something pressure relieving in between, makes a lot of difference. Because what I noticed after prolonged procedures, patients wake up and don't complain of any pain in the chest or the drain or the shoulder. The complaint is mostly back pain, neck pain, or hip pain. I would say when we're using a combination of local anesthetic, magnesium, in patients with atrial fibrillation and a high degree AV block, I would caution that I would just give one agent or the other and see how it goes, purely because I have had one patient, and it wasn't a thoracic surgical patient, it was a cardiac patient when we were doing opioid free, that developed complete heart block with it. N equals 1, and we've done over 900 cases. I've not had a problem since then, but I'm still cautious. When we started doing opioid free, we started with a dexmedetomidine infusion, but unfortunately, dexmed is not readily available in the anesthetic department in our trust. So necessity being the mother of invention, we started doing clonidine infusions. And what we noticed that with infusions, like I said earlier, our patients were a lot drowsier. So we went down to just 150 micrograms of clonidine. And even then, my patients were drowsier. So trial and error, I came down to a dose. So if they're under 60, I give them 1 mic per kilo. If they are elderly, I even go down to 0.74 or half a mic per kilo of clonidine, and that seems to be enough. We had a lot of issues with shoulder tip pain, and those of you doing thoracic surgery would know it's quite difficult to treat it. But ever since I started using a combination of PHRENIC block as well as intrapleural lignocaine, I've had no cases of shoulder tip pain. I have had a question on here which is very interesting. Does ketamine have a role? And I should have included it on the slide. And when I first started, I was giving them 10 milligrams of ketamine. At some stage, we were giving 20, 25 milligrams of ketamine in the beginning. And what I found that there was no, for want of a better word, I didn't find that once I have a good block and I'm using all the other things to control the blood, maintain sympatholysis, I didn't feel the need of using ketamine purely because it wasn't adding anything to the value. There was nothing value added to it because they were so effectively analgesics that having ketamine purely increased their risk of being a little bit, it increased the time in recovery. They were a little bit more confused, especially the elderly. The patients that I will continue to use ketamine on are the chest wall resections and the major resections that we do. I think ketamine does have a small role in that. There is a learning curve when it comes to opioid free anesthesia because we don't have that safety net of using 10 milligrams of morphine. So every little thing that you have to do has to be perfect. So I have had patients waking up with sore throat. I've had patients complaining of heartburn. I've had patients complaining of ankle pain, hip pain. So everything that you do has to be perfect is what I've realized. And you have to collaborate with your surgeon because at the end of the day, they're the ones doing the PHRENIC block and intercostal block. And I think this belt and braces approach really works because sometimes you could have a missing segment with the paravertebral. I should have mentioned I do my paravertebral at 3 different levels. Some of my colleagues do it at 2 levels, but we don't tend to put a catheter in because I think the patients just get tethered to it. The reason we're using we're using PCA still after 4 years is logistical more than anything. We, like everyone in the NHS, have severe shortage of nurses on the ward. Our wards are increasingly busy with higher acuity patients, and we simply don't have nurses who have time to go around looking after these patients. So I think for that reason, and also with the PCA, I have control, and because I do the pain rounds, I know exactly how much morphine they've used. So just to give you an example, I just finished an audit 4 months back of all the patients I anesthetized last year. There were about 250 patients. And not to go into details, but they broadly fall into 3 groups. The first group is a PCA consumption of less than 5 milligrams in 24 hours. The second group need anything between 5 to 15 milligrams in 24 hours. And the third group will require anything between 15 to 20 milligrams. And there's always 3 or 4 patients who I describe as analgesic failure that you would find in all the clinical studies, or when it comes to pain, who need 40, 50, 60 milligrams. And these are the patients then we move to ICU and start them on an ultra low dose ketamine infusion, which is 1 milligram an hour. Which patients I don't do opioid free in? They are the big chest wall resections where we take 3, 4 ribs out and do a reconstruction. Patients with empyema who are obviously septic, there is no value added to doing an opioid free anesthetic technique, because you don't want to be putting needles in infected patients in their paravertebral spaces. Inability to perform nerve blocks. So patients with severe kyphoscoliosis who may have difficult paravertebral spaces. I think it's a relative contraindication rather than an absolute one. Patients with sepsis, again, if they're going to ICU afterwards, there is absolutely no point in doing it. Pushing boundaries, what we've started doing is we've done about 20 cases of opioid-free cardiac anesthesia, but that we haven't really managed to get this off as a formal program. I personally combine spontaneously ventilating thoracic anesthesia with opioid-free, so we keep them spontaneously breathing on sevoflurane with a laryngeal mask or an iGel, and combine that with an opioid-free technique, and that works well. I do a completely non-intubated pleural surgery, so if they come for pleurodesis, we use the same technique as opioid-free, but keep them completely non-intubated, just a Hudson mask with a propofol infusion using a TCI. Interesting thing about pleural surgery is that I think, in my mind, the jury is out whether or not to keep the technique purely opioid-free. The reason being, the pleural inflammation is extremely painful, and most of these are young patients. What I've started doing is to give them all the things that I do, all the adjuncts that I use for opioid-free with the same block. And although the pain score in recovery is good with pleurodesis patients, at 24 hours, they do use quite a lot of morphine. We do opioid-free spontaneously breathing subxiphoid thymectomies for the myasthenia gravis patients. So we use a laryngeal mask and keep them spontaneously breathing. We do a lot of lung volume reduction surgeries in patients with severe emphysema with FEV1 less than 0.3. And in this subpopulation of patients, opioid-free anesthesia works really well because the analgesia is good, and also with no opioids on board, there is no risk of respiratory depression, and they wake up coughing well. Opioid addiction patients, I've had 4 patients in the last 5 years where they were current heroin users with high dose of methadone at the same time. And we have a very good substance abuse team at Cambridge University Hospitals next door. So in working together with them, we managed to anesthetize all 4 of these patients with a completely opioid-free technique, and kept them on a higher dose of methadone for analgesia afterwards. So we didn't use any PCA for 4 of them, and the technique works. So in 2019, built on all the successes of what we've done, I anesthetized the first opioid-free, non-intubated, spontaneously ventilating the right pneumonectomy, and that was one of the world first. The patient stayed in hospital for 3 days and then went home. And really, since then, the technique is almost commonly used in our hospital by everyone. So yeah, that's the end of my presentation. I'm happy to take any questions if you